SmithKline & French Laboratories is pleased to bring you this ongoing series of highlights from the 7th Annual Vail Conference of the Menninger Foundation, Update on Schizophrenia. Dr. Thomas H. McGlashan begins this program with hospitalization for schizophrenia, including long-term treatment. Dr. McGlashan is Director of Research at Chestnut Lodge Hospital in Rockville, Maryland. Now here's a brief message from SmithKline & French Laboratories and SK&F Co. about Stelazine brand of trifluoperazine hydrochloride.
The human touch, sound of the human voice, understanding, warmth, reality. When your chronic schizophrenic patient suddenly, perhaps violently, loses touch, the potent action of non-addictive Stelazine injection promptly reduces hallucinations, delusions, and other core psychotic symptoms. With these disruptive symptoms under control, the wide variety of Stelazine dosage forms and strengths enables you to easily make the transition from intramuscular to oral dosing for effective maintenance therapy. You will be pleased to see that Stelazine maintains your chronic schizophrenic patient through effective control of psychotic target symptoms. And since, as you know, Stelazine apparently activates withdrawn, apathetic, or detached patients, you have a greater opportunity to reach your patient with other forms of therapy. Your patient suffers less, responds faster. In addition, Stelazine offers these treatment benefits. Stelazine seldom causes excessive sedation. Stelazine demonstrates a low risk of anticholinergic effects and orthostatic hypotension. Stelazine offers convenient, economical BID dosage. And while Stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics, when encountered, these symptoms are generally readily controlled. We urge you to prescribe prompt-acting, non-addictive Stelazine for your chronic schizophrenic patients because the way back begins with the human touch, sound of the human voice, understanding, warmth, reality. Because the way back begins with your healing touch.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions such as pseudoparkinsonism, potentially irreversible tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with Stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing Stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Be sure you're the doctor. Always write Stelazine DAW. Dispense as written. Now here is Dr. Thomas H. McGlashan with highlights from his talk on hospitalization of schizophrenia, including long-term treatment.
My topic concerns the hospital treatment of schizophrenic patients. Hospitalization used to be simple. It was asylum. Now, however, hospitalization is a part of active treatment, and diversity reigns. We have the emergency layover on the one extreme and long-term residential treatment on the other. We have full and partial hospitalizations. Three types of programs are particularly common and frequent, and I would like to describe them. First is short-term hospitalization with focused goals. Here the goals consist basically of reconstruction to premorbid levels of functioning and return back to the mainstream as soon as possible. Lengths of stay are measured in days and certainly no longer than 2 or 3 months. Most such units are medical in orientation, and they serve populations who are acutely disturbed and generally refer subacute and chronic cases elsewhere. At admission, modest and realistically obtainable goals and expectations are clearly outlined to the patient and family, as are the rules of acceptable conduct and behavior. The milieu staff, in turn, clarify their limited role in the patient's life, avoid treatment aimed at providing a good relationship, and stress real relationships. Second is short-term hospitalization with extensive goals. In this special but not uncommon situation, the hospital goals are focused, but the treatment goals are not. The patient is usually engaged in some form of long-term outpatient treatment, like individual or group psychotherapy, but encounters a need to be hospitalized for reasons that are often related to the outpatient treatment. The goal of such hospitalization, beyond the immediate issue of safety, is to protect the viability of the outpatient treatment framework. The primary therapeutic alliance remains between the patient and the outpatient therapist, who usually continues to see the patient during the residential period. Nevertheless, while the patient is hospitalized, the extensive treatment setup can undergo a thorough evaluation and overhaul, with the hospital serving as consultant. The result may either be a strengthening of the ongoing effort or its dissolution and replacement with something new. Patient populations in this situation run the gamut from acutely to chronically disturbed. Lengths of stay are usually measured in weeks. The therapeutic administrator split, the TA split, is commonly employed, with the hospital taking the administrative role. The milieu's goals are limited. Accordingly, interactional strategies correspond to those that are described for short-term hospitalization. Discharge planning is abbreviated and focused upon returning the patient to the extended treatment framework. Third and last is long-term residential treatment. These programs basically serve chronic populations with histories of repeated treatment failure. Whatever the goals, however, treatments tend to derive from some form or variation of the intensive psychotherapeutic model. Lengths of stay here are seldom less than 6 months and usually extend into 1 or more years. In long-term residential treatment programs, a significant proportion of the treatment comes from being in residence. That is, from living for an extended period of time with new people in an accepting and structured or holding environment. The milieu is designed to encourage the development of long-term, meaningful relationships. They are regarded as the foundation of treatment, especially with patients for whom more technical and manipulative or ego-oriented strategies have failed. The hope is for resumption of emotional growth and development by new attachments which, through observation and insight, are rendered more resistant to destruction by old distortions and disillusions. Long-term milieus are generally organized around a primary psychotherapeutic relationship. Unlike short-term hospitals serving extensive goals, however, the primary therapists here are intramural, thus preventing frequent mismatches between therapist and milieu over treatment philosophy. The milieu staff support the primary relationship and echo it in their frequent individual and group interactions with the patient. As such, patients' defenses are confronted, not supported. Their transferences and unconscious conflicts are addressed, not avoided. Observations are feeling-oriented versus behavior-oriented, in the service of helping the patient to do what Semrad called acknowledging, bearing, and putting into perspective his and or her painful life experiences. Responsible behavior is expected of the patient, but regression is not viewed as a major cause for alarm. It is regarded as informative and as a potentially adaptive precursor to more flexible coping strategies. Since functional deficits are very common in chronic patients, rehabilitative strategies, both social and vocational, are also vital aspects of long-term programs. So too is adequate aftercare. Long-term residential treatment, despite its length, is still only a beginning for chronic patients. Institutionalization and chronic and continuing disability demand continuity of care beyond discharge if the gains of hospitalization are to be consolidated and extended. I'd like now to stop talking in abstractions and present a case, which I think will illustrate many of the treatment principles and strategies which are outlined. The patient is Donald Q., a 27-year-old white single male, admitted voluntarily to Chestnut Lodge in the early 1960s with a clinical diagnosis of chronic paranoid schizophrenia. His first symptoms began during his sophomore year in college at age 19 and consisted of increasing anxiety, withdrawal from his roommates, sleeplessness, agitation, and changes in visual perception. This culminated in a poorly described religious experience on the lawn of his fraternity house, requiring hospitalization for 2 days in the student infirmary. After his discharge from this, Donald found it impossible to continue with school and decided to go home and enter outpatient psychotherapy. He remained in treatment over the next 4 years and made several attempts at employment in school, but achieved only a tenuous adjustment. During the next 4 years, Donald was essentially hospitalized continuously. He received an unknown number of electroshock treatments. His last hospitalization prior to transfer to Chestnut Lodge was the longest, lasting 2 years, and he was asked to leave that institution because of increasing assaultiveness. He arrived at Chestnut Lodge heavily medicated with Haldol. On admission, he appeared to be so confused that, in the words of the admitting physician, the clinical picture suggested a mentally deficient individual. He asked for the simplest questions to be repeated, and his speech was characterized by impoverished content. His affect fluctuated widely between flatness to disruptive and provocative outbursts of anger, while at times he responded to questions with inappropriate, silly laughter. His appearance was disheveled and his behavior careless, and his inability to tolerate the admission interview prompted his being escorted almost directly to the unit. Brief family history. Donald was the first of 2 siblings from an upper-class family. Mother was described as a dynamic, attractive woman who could be very seductive with the patient and quite obsessive about his health as he grew up. Father was described as friendly, intelligent, cooperative, and compulsive. He was also a very successful and self-made entrepreneur. Both parents supported the patient's hospitalization, although Father was frustrated by its length. There was no known family history of mental illness. In terms of growth and development, Donald's mother had an uneventful pregnancy. Donald's delivery, however, was very difficult due to a breech presentation. Donald had to be turned in the womb, and this resulted in severe postpartum hemorrhaging for Mother, requiring numerous blood transfusions, 2 months in the hospital, and a lengthy convalescent period of approximately 6 months, during which the patient was cared for by a nurse. When the patient was 3, a sister was born, and from birth she had many serious physical problems requiring surgery. Closely following upon this event, Donald began experiencing night terrors, and he developed asthma. A pattern of timidity was also noted at this time. Donald did not run and jump like his contemporaries, for example, but walked very carefully. This sister, who was subsequently diagnosed as mentally retarded, died of complications of a seizure disorder when Don was 7 years old. He did not cry or talk about her death, but became what was called a chronic behavior problem both at school and at home, although the details of this were not in the record. He was also a good student, however, and graduated from high school quite high in his class. He entered a university at age 18 and did superior academic work. But he became more intense and preoccupied with questions about religion, life, and sex as time passed. Eventually, he had the religious experience alluded to previously that led to his first hospitalization. All told, Donald spent about 5 years at Chestnut Lodge. At least once a year, every patient at our hospital is the subject of an extensive case conference. And at this meeting of the treatment team, the administrative and psychotherapeutic work gets reviewed. And for about the past 45 years at Chestnut Lodge, this case conference has been transcribed and typed up. And it is from this record that I will try to reconstruct and document his therapy. Donald Q. was admitted to one of the standard lodge wards, an 11-bed locked unit. Shortly after his admission, he was assigned a psychotherapist, Dr. K. He was withdrawn from Haldol, but then placed back on it at 4 months. Most every patient who came to the hospital was taken off of medication. It was also standard at that particular time at Chestnut Lodge to leave them off of medication. So his being placed back on neuroleptics at 4 months was unusual. Donald is described on admission as being very fragmented, disheveled, and unkempt. He often appeared to be hallucinating, giggled a great deal, and mumbled frequently in delusional and paranoid ways. Despite this basic clinical picture of dilapidation and chronicity, Donald also managed to convey something which it's hard to describe, but caught people's attention and engaged them. The head nurse, for example, said that there was something likable about him. Here's what the head nurse said. One day I had it up to my ears, and everything was flying, and that's exactly what I mean. Chairs and everything. And I looked at Don and I said, I'm going for a walk. Do you want to go? And he looked at me and said, me? And I said, yes. He said, okay, wait till I comb my hair. And then I knew it was going to be safe, and we started the months of walking together. The patient psychotherapist, Dr. K, went to Don's unit and met with him for 30-minute sessions 5 times a week. The first phase of the work, as described by Dr. K, was one in which Donald presented himself as out-of-contact, negativistic, aggressive, assaultive, openly psychotic, and delusional. After about the first 6 months, the patient and his therapist began taking short walks off the unit on the grounds of the hospital. About this, the therapist said, on the one, Don used me to get the hell out from under the madhouse of the unit, but as soon as we got out, of course, he would have nothing to do with me. He would tell me to go to hell. We would walk around the grounds and get back to the unit, whereupon he would shoot me at the door with his fingers and tell me to come back in a year. On the unit, as we sat together, he would smoke cigarettes, and he would be clutching his radio, which was masterfully tuned to static. Gradually, however, Donald came to tolerate the interaction and to begin to verbalize and elucidate what was on his mind. He eventually came to Dr. K's office consistently and was verbal. He gradually became more open about his anger, his sexual feelings, the past, his parents, and so on. Don seemed to be getting in touch with a great deal, but not in a way that was consistent or repetitious. According to Dr. K, Don's transferences at this time seemed to be rather multiple and shifting. He could see Dr. K as father, mother, a longed-for brother, a probing Nazi, or an insignificant non-human object. The important thing was that a relatedness had been established, and it was assuming more and more the character of a therapeutic kind of relatedness. The work slowly but surely becomes more affect-laden and transference-related. He presents more comments about loneliness and starts to have weekend separation reactions. There's a greater dependence and a growing mutual positive regard. Over this time, Don becomes more functional, and it looks as if he's on the threshold of taking first steps into the community. At this time, unfortunately, a decision is made to try reducing his medication, and Don was brought down to what would be regarded now as a homeopathic dose. This particular strategy, combined with the pressures he was obviously experiencing with regard to leaving the hospital, precipitated a regression. He became psychotic, fragmented, delusional, and quickly lost practically all that he had gained in 3 years. In some ways, this regression was even more flamboyant than when Don was admitted to the hospital. There was a great efflorescence of positive symptoms, and he was so assaultive that seclusion and cold, wet sheet packs had to be used for the first time. He was, of course, placed back on higher doses of antipsychotic medication quickly. What was disaster at one level seemed to be progress on another, and important therapeutic issues came to the fore. Again, I cannot improve upon Dr. K's own words. I saw Don the first hour with him in cold, wet sheet packs. He had slugged one of the aides a couple of times. In that first pack, Don is screaming at me that this would kill his mother, these efforts to become a person, to separate and grow up, and that he was terror-stricken by that. The regression was rapid, the aggression was violent. We were all at our wits' end to contain the psychotic temper tantrums. At this time, I went through it with him, whereas the other time, it was all kind of his own. During this time, the regression diminished more rapidly than before. And over the next 6 months, Don managed to work his way back to the same point where he was at when the regression began. Many important issues were elaborated. such as Don's terror of growing up. Virtually none of these issues were new. But the overall feeling one gets in reading this record was that Don, perhaps for the first time in his life, was not dealing with these issues alone. Again, I cannot improve upon Dr. K's own comments. Don made some decision when he was 3.5 or 4 years old that sexual and angry feelings were not allowed. They could destroy his sister, whom he was invited to protect. They could destroy his parents. So he had to live his life as a good son, dutiful, and any bridging of that narrow road is punished viciously by superego that takes out, as he says, half his mind or half his body whenever he transgresses. That is, whenever he feels a feeling. That's a transgression. Individuating and becoming a person in particular is a transgression against mother. When he was in PAC for the first few days of his regression, he said to me with great anguish, "Doc, you have got to stay with me, but I can't do this analysis. I can't do it. I can't kill my mother. I can't do this." It was said in a way that we were hearing not just about mental representations. There is an existential reality in his anguish that I don't have much of an answer for, except to say as best I can that I'm still committed to a person becoming a person and an individual. Once Don recalled that one of his first pets was a dog. With a lot of tearfulness, he outlined that this dog could not be toilet trained. He recalled with a lot of pain and rage how his father would beat the hell out of the dog for crapping around, occasionally throwing the dog downstairs. He recalled how much he was relieved but dreadfully sad when the family reached the decision that they could not handle the dog and that they would find a good home for it on a farm. He described how at age 4, almost like an adult man, doing what he knows is in the best interest of another, yet so painful to do, giving his dog his last good petting rub on the stomach for half an hour, back scratching and petting rub, and how he knows that the dog did pretty well out on the farm, and how much he in certain ways has been trying himself to find some farm, and how he recognizes symbolically his being torn in half between having to leave home in order to survive and how painful that is. After this phase, Don progressed relatively rapidly to the point of outpatiency. He sought and obtained employment and lived outside the hospital. In therapy, Don continued to ruminate seemingly ad nauseum about many of his now well-established issues of hostile dependency in the transference, as well as his concerns that any kind of assertiveness, including that involved in individuation, was somehow destructive. What emerged was the enormity of his endearment to this image of himself as small, weak, and dependent. Interestingly, Dr. K describes this phase of the work as repetitious, and, in fact, it becomes boring to him. It was as if Don was elaborating all of these issues in the service of maintaining the dependence. In a way, signaling a change in the relationship, Dr. K did a rather uncharacteristic thing. Again, his words serve best. For what seemed like 4.5 years of hearing the same thing, I shouted out and expressed to him in an hour that I would be goddamned if I was just going to continue to be with somebody who was murdering his mind every goddamn day and just telling me about it and saying that that was the way it was and there was nothing else to do. I told him that he could just, as far as I was concerned, take his goddamn mind-murdering self and to work with somebody else. The response was interesting. Don was hurt, as you can imagine, and frightened, and Dr. K very chagrined and guilty for this outburst. Nevertheless, from that point on, integration ensued, and the therapeutic work, as I can reconstruct it from the transcriptions, became more of a task of putting issues into perspective and working through. Don, for example, finally began talking about the transference as transference, and specifically about his emotional need to keep Dr. K idealized. How well Don grappled with this difficult phase of treatment may be estimated by one of the last things it is reported he said in his work with Dr. K. Maybe you are not Dr. Freud, but maybe I think we can come out of this. I can get on with my life. My mother criticizes me. I'm never going to be president, never going to be that congressman, but I can be an ordinary person. Donald's prediction about becoming an ordinary person seemed to hold. I know that because we interviewed him on the telephone 10 years after his discharge as part of the follow-up study that I have conducted over the past 6 to 8 years at Chestnut Lodge. Now, Don was 42 at the time of his phone interview, and he'd been out of Chestnut Lodge for about 10 years. For the first 3 interim years, he had stayed in the Washington area and saw his lodge therapist in intensive psychotherapy as a private patient. Over the past year, in the follow-up, he had checked in periodically with a therapist in his current locale on the West Coast. He took Haldol over the follow-up period in decreasing doses, and at the time of follow-up had been on 2 milligrams per day for the past 4 years. He had had no further hospitalizations, and he had been employed continuously since discharge and currently worked as a salesman for his family's retail electrical supply outfit. Don had been married for 2 years, and he and his wife lived in their own home. He described his marriage rather succinctly. It's not a dream, but improving. I feel I have done okay since leaving the lodge. I am still struggling, however, but seem to be overall holding my own. The lodge brought me from deep illness to competent social functioning. Yet by my standards, I have a ways to go. He was contemplating re-entering analysis, which he felt was incomplete. He said that he had stopped treatment when he did, and I could only agree with him, as he said at that time he was tired of 15 years of doctors. There are obviously many questions to ask. I think intensive long-term observation of single cases, like the case of Donald, can help in the process of teasing forth answers to some of these questions. I should emphasize, however, that this line of inquiry does not address questions of cause and effect. That is, it cannot demonstrate that the outcome we see with Donald Q was caused by the therapeutic process that he underwent at Chestnut Lodge. The only way to address the causal question or the causal connection is with studies designed utilizing comparison groups. Nevertheless, I think it's very important to describe the process of treatment in cases with a variety of known outcomes in order to build, in a sense, a typology of processes. In our field, at the present time, the science of treatment must become busier with refining classifications, much like our science of diagnosis, which operates without ostensible knowledge about etiologies. We must be content with refining categories and subgroups. Donald's treatment proceeded roughly in the phases that I outlined earlier of engagement, elaboration, toleration, and then integration and working through. The phase of integration was preceded by a massive, though more readily contained regression. This undoubtedly resulted in part from the decrease in Donald's medication, but it may also have resulted from the shifting demands of the psychotherapeutic work characteristic of the integrative phase. At any rate, one gets the sense that this second regression was more useful psychotherapeutically than Donald's first regression. It seemed less autistic, more shared between patient and caretakers, and from the follow-up, although I didn't have a chance to detail it, it sounded like it became a more important piece of history for him. It was something that he remembered quite vividly. And I would suggest that the principles and the phases of treatment that I outlined may not have changed all that much. The severity of Donald's psychopathology required an inpatient structure, but I would wonder if the vicissitudes of long-term treatment are radically different for healthier outpatient schizophrenic and borderlines. To conclude, what are the implications of long-term residential treatment of schizophrenia for current clinical practice?
systematic investigations, including our own follow-up study, dictate modesty. And yet I still maintain that long-term hospitalization as a form of treatment should be an option for those patients who prove recalcitrant to standard efforts. There is far more that we don't know about schizophrenia than we do know. And until we make significant inroads upon our ignorance, schizophrenia will remain heterogeneous and the individual patient quite unpredictable in his or her ultimate course. Therefore, I say it is dangerous to overgeneralize on what we do know and, for example, automatically confine a patient who has been ill for several years to a chronic outcome. The individual can still surprise. This concludes the discussion of hospitalization for schizophrenia. Please turn the cassette over for further remarks by Dr. McGlashan on group psychotherapy with schizophrenics, as well as a discussion of family therapy and schizophrenia by Dr. Loren Mosher.
Our program continues with Dr. McGlashan's discussion of group psychotherapy with schizophrenics. Following Dr. McGlashan is Dr. Loren Mosher, Professor of Psychiatry, Uniformed Services University of the Health Sciences, Bethesda, Maryland. First, this brief message from SmithKline & French Laboratories.
The fragile shell of the borderline patient. Like the shell of an egg, it may be seamless, secure.
Your borderline patients may manage a career, family relationships, rewarding friendships, until the pressure builds. Pressure to the point of overwhelming stress.
Then the fragile shell may crack. Psychotic symptoms emerge.
You can help return your borderline patients to reality by controlling emerging psychotic symptoms with the short-term use of non-addictive stelazine, brand of trifluoroperazine hydrochloride. And because stelazine seldom causes excessive sedation, your patients will remain more alert to other forms of therapy. Stelazine offers a convenient, economical BID dosage regimen that helps ensure compliance.
When the fragile shell of the borderline patient cracks, remember, stelazine controls occasional psychotic symptoms.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, such as pseudo-Parkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and/or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Be sure you're the doctor. Always write stelazine DAW. Dispense as written. Now here is Dr. McGlashan.
Aside from its value for studying primitive psychodynamics, does the group experience offer anything with therapeutic value? Now, social relations are certainly central in the recovery from psychotic episodes, as outlined by Breyer and Strauss in an article that they wrote for the American Journal in 1984. They noted that too little attention has been paid to the positive effects of social relations upon a patient's course, and they listed 12 helpful functions of social relations: ventilation, reality testing, material support, social approval, and integration into a social network, constancy, especially in times of crisis, motivation, modeling of adaptive behaviors, symptom monitoring, giving them feedback on how they look and appear to the external world, problem solving, empathic understanding, reciprocal relating, meaning giving the patient an opportunity to give and to experience giving, and finally, insight. Unquestionably, social relations have powerful therapeutic potential. Social relations are also, however, what the schizophrenic disease process paralyzes or distorts the most. So we have a catch-22. The schizophrenic patient needs social relations the most, but is also able to use them the least. I think this was reflected in the rather poor early impressions about the efficacy of group therapy with schizophrenia. Loren Mosher and John Gunderson, in a 1979 contribution to Bellac's volume, reviewed studies on group therapy up to 1976. They felt that the literature showed little unique contribution of group psychotherapy to the usual hospital treatment for inpatient schizophrenic patients. The results were more or less the same for outpatient groups as well. Sam Keith and Susan Matthews, in a 1982 contribution to the Psychiatry Update Annual Review, did not have a very different message about group therapy. I quote them: "For a modality that is in such wide use and has been the subject of such intense research for the past 20 years, these minimal conclusions can only be described as disappointing." This past October, at the 8th International Symposium for the Psychotherapy of Schizophrenia at Yale, Nick Kanas reviewed 40 controlled studies of group therapy in schizophrenia. That is, where group treatment was compared to no group therapy controls. First, there was a preponderance in favor of group therapy, and furthermore, this increased the longer the group therapy was conducted. In the outpatient studies, there were 10 that he reviewed, and 80% of those studies, 8 out of the 10, the group scored better than the control. The other point, I think, major point, which he made in his review and presentation was that the type of group therapy also made a difference. Insight-oriented groups were the least useful and at times were demonstrably anti-therapeutic. In contrast, he found the groups that discouraged exploration but encouraged interaction, reality testing, and support were the most useful. Irving Yalom came to the same conclusion, that traditional group therapy, traditional in the sense of insight-oriented, exploratory, was not helpful to schizophrenic patients, but that other forms of group interaction were definitely useful. Now, groups can offer far more than insights, since many of the groups that he studied offer just about everything else except insight, and are found to be efficacious. And I think groups offer some patients an opportunity to modulate the intensity of interaction in the psychosocial sphere while maintaining a connection and attendance with caretakers. Some chronic patients can be relatively passive, withdrawn, and silent without feeling under intense pressure or demand to communicate that they might experience in a more personal one-to-one relationship. Now, most groups fall into one of two types: shorter-term inpatient groups and longer-term outpatient groups. Let's look a little closer at each, focusing first on the inpatient groups. They are usually in length dependent upon the length of the inpatient stay, which these days is measured in weeks. The composition, because most of the units to whom patients are admitted are heterogeneous, is a mixture of diagnostic groups. The recommended frequency is 3 to 5 sessions per week, between 45 and 60 minutes in length. Again, the length being shorter, since patients' attention span in the acute phase of their illness or hospitalization tends to be much shorter. The leadership that's recommended is co-therapy. The boundary refers to whether the membership is open or closed, stable or changing. The boundary really must be open, since the turnover of patients is very rapid. And attendance is usually suggested that it is expected and it is mandatory. on the inpatient units. Again, because a great deal of structure is often needed for these patients who are more regressed, and that it should be part of sort of the daily routine on any inpatient unit. Yalom notes that the inpatient group can be heterogeneous. He calls this the team group, and it includes all patients on a particular ward, or what he calls a level group, where patients are segregated in some fashion, either by diagnosis or by level of functioning. The advantage of the team group is that all patients are involved, and so you certainly are being comprehensive in including everyone on the unit. The disadvantage, of course, is disorganization, and it's hard addressing both high and low functioning patients at the same time. Now, inpatient groups pursue some of the following goals and or functions. First, elevating staff morale and facilitating their conduct of patient evaluation. Second, encouraging supportive, respectful, and cohesive interpersonal relations among patients both inside and outside of the group. Third, correcting maladaptive interpersonal patterns and developing social skills. 4, discovering that one's problems are not unique, reducing isolation. 5th, exploring affects and fears in a safe, controlled environment. 6, learning that talking helps and learning how to use it in the interpersonal maneuver. 7, seeing others improve or instilling hope. 8, helping others improve or experiencing altruism. 9 is reality testing and giving or receiving advice and practical feedback. And 10, providing a pleasant and constructive enough therapeutic experience to encourage continued participation in the longitudinal treatment system following hospitalization. The technical strategies common to short-term inpatient groups are many. In general, the therapist works in the here and now, endeavors to provide an experience of success, and only introduces tasks capable of completion. Unconscious conflicts, transference, and uncovering are minimized. Acting out of aggression is firmly controlled with rules, timeouts, dismissals, or restraints. Expression of anger is discouraged, either by changing the subject or displacing it outside the group, talking about someone outside the group or talking about someone in the past, or focusing it on one of the co-therapists, or both of the co-therapists. Emotions, especially loneliness and depression, are encouraged, are ventilated, and they're labeled. Symptoms are shared and scrutinized, and strategies of reality testing are discussed. Social skills like eye contact, active listening, greeting, and sharing are taught and modeled. The therapists are active without being intrusive or judgmental. They find something positive to express about the behavior of every patient. They frequently disclose personal feelings, ideas, and interests to promote and to model interactions. The group meeting is structured according to a consistent procedural sequence. Yalom, in particular, adheres to a particular sequence of 4 parts to a group meeting that he labels orientation, warm-up, specific exercises, and session review. The more regressed the group membership, the more the leaders introduce structure, such as physical exercises, didactic presentations, changed seating arrangements, role-playing, talking go-arounds, games, and homework assignments. Now to get to the outpatient groups. These groups are, first of all, usually longer term and months in duration, and they usually meet for a longer period of time, for 60 to 90 minutes. They can be larger, 5 to 10 members, because the patients are usually more stable and less floridly psychotic. Co-therapy, again, is generally recommended, although not as stridently as it is for the inpatient groups. Attendance is usually considered optional, and it's more the patient's responsibility, and they are not prodded or nudged as actively as they are in inpatient groups. Membership may be open or closed, and composition is usually diagnostically and prognostically homogeneous. These groups share many of the goals that I outlined for inpatient groups, and in addition, outpatient groups also aim to prevent psychotic relapse, to help the patients manage their medications and their side effects, and to provide some practical help in problems of living and working and adjusting in the community. These groups also provide caretakers with a forum for regular in-depth evaluation of aftercare patients. Now, higher level groups also try to do more than this and to develop new patterns of behavior and of coping by increasing awareness of adaptive and maladaptive behaviors and by considering and practicing alternate coping strategies. The technical strategies generally follow those outlined for inpatient groups. Occasionally they're more traditional for higher functioning groups. Usually they're more concrete for lower functioning groups, and things like providing coffee or food or advice, prescriptions, and psychoeducation. Now, certain considerations are frequently important, like the ratio of activated to withdrawn patients in the group. O'Brien feels that 1 or 2 withdrawn patients may do well in a group of activated patients, but that the reverse is a poor fit. The literature states that group therapists should be mature, stable people, capable of tolerating a lot of chaos. O'Brien feels that the best training for group therapy with schizophrenic patients is supervised experience with individual patients, plus a period of apprenticeship as a co-therapist. And co-therapy, as mentioned, is considered to be best. 2 leaders provide for the dilution of transference, for sharing the work, for consensual validation of process and dynamics, for coverage for vacations, a very practical matter, and for modeling of healthy interpersonal relationships and healthy sex role relationships in male and female teams.
We'll turn now from Dr. McGlashan to Dr. Loren Mosher and family therapy and schizophrenia.
It is really quite true that the families that have a schizophrenic offspring communicate in different ways than other kinds of families, and in discernibly different ways, and in ways which are not that hard to figure out. I mean, not hard to identify. You don't have to be a genius to do it. It seems to me that when you're thinking about families who produce certain kinds of disorders, you want to think, well, why is this kid crazy in this particular way rather than some other way? And that has to do with the specificity question. The thing I look at is, as you sit there and discuss whatever topic it is you're discussing, is who talks to who, and who responds, and what are the responses like. Then, in terms of the content, I look for examples of communication deviance. It's a term which Wynne and Singer have used to summarize a whole series of ways in which people fail to communicate in a clear, understandable, goal-directed, relatively precise way. It's a clumping of maybe 15 or 16 different subcategories, the total of which comes out what they call communication deviance. It's basically families that cannot attend to a question, follow it logic to an end, and get an answer. And communication deviance, if you will, is like a mild form of what is called thought disorder in the patient himself or herself. Then the selection question. Well, you can say it's genetics. Okay. But since I can't do anything about genes, I will think to myself, why this kid and not that kid or that kid? What was going on there? Generally speaking, that kid is special. And even if they've never been to a mental health professional in their life before, they don't know anything about theories of madness or any such thing, very naive, the family will tell you, well, Johnny has been special and unique and different since very early on. The single most common reason for that I have come across clinically is that child is a replacement for somebody one of the parents lost about the time of that pregnancy and birth. That can be a brother, a special aunt, a parent, a very good friend, and you will find very often that particular child is named after cousin Charlie, who was killed in an accident when mom was pregnant with this child. And so from then on, he is as much cousin Charlie as he is Charlie himself. And that is the commonest thing I've found. You also can find that very often it is one of the parents who will have a much greater investment in that particular specialness than the other. Because, generally speaking, if my mother dies, it's more important to me than it is to my spouse, affectively speaking. And so you try and figure out which of the parents is more involved in the specialness. Then we get down to basically what is the systemic question. How is this dance orchestrated? So everybody stays on the dance floor, follows the steps according to the rules, and never leaves. How is it maintained? And the orchestration of that dance is the most difficult part of the assessment, because it's always hard to figure out exactly what someone does to make sure that no one really changes or leaves the situation. How do they all contribute and all get something out of one person being in a particular position in that family? I practice a lot of meta-communication myself. I ask questions which are clarifying, and clarifying questions are, by definition, meta-communication. One of the defining characteristics of family with schizophrenic offspring is that they don't know very well how to communicate. Either they don't know how or they don't do it. They don't ask questions like, what did you mean by that? The amount of distortion which can go on in the communication process in these kind of families is quite amazing. And I try as best I can to correct them as they come up. And what I try and do is to teach the family basically to correct those distortions or incorrect attributions over time. My own way of dealing with families has moved. I started with a very communicational sort of approach. I figured if you could teach people basically clear communication, and that if you gave them things like homework and ways of making sure they were always communicating clearly, that the madness would go away. I've moved much more to the use of paradox and other things which did not come out of the family research literature, came out of more the clinical side. The role of the patient is one which can become a career, and as a career can be painful to all the participants, the person in the career and the rest of the family. And that's why families report so much pain from having amongst them someone who is embarked on a career of being a chronic mental patient. And if a family is going to get out of that, is going to change that in some way, I have not found that the communicational approach that I learned early on and used early on was terribly effective in that regard. Lately, I think various other techniques, reframing, validation, paradox, remoralization, education, are really much more helpful. The one technique which I like and which I learned from Mara Salvini is the one about, you get the family in and you do one of her big brouhahas, and then at the end you send the offspring out, you bring the parents in, and you said, we're going to give you a prescription, and your prescription is that you must go out one evening a week, and you leave a note for Jane or Joe and say you're going out and you'll be back at 11 o'clock. You don't prepare supper, you don't do anything except say that or even tell them where you're going. And you must do that one time a week. Now, already you have there a family that has, in all likelihood, given up its relationship to its usual social network and has focused most of its energies on this problem that they have, which is a person with a quote-unquote chronic illness. And a lot of the same stuff does go on in families with diabetics and so forth and so on. So it's not unique to these kind of families, but if the aim is to try and spring the offspring from the family, that technique of Mara Salvini, in the times that I've used it, has been rather successful. And it's a real trick. It says we've gone through all this big thing, we have this relationship, and now I'm going to give you this prescription to go out one night a week. And then when they come back, you find out if they did or didn't, and how they did it, and then you can discuss that as the issue of how they couldn't do it, and so forth and so on. I do think families that are stuck in long interactional patterns where everybody has pain and everybody is complaining, but it has not changed in several years, and they are all sort of dug in together at home, those families are the ones for whom I find paradox may break up that equilibrium, or can at times. The equilibrium is so powerful, though, that sometimes it's just a waste. People who are not very experienced think paradox is the cat's meow for all things at all times, and forget about the relationship problem. You cannot do a paradox unless you have a very strong relationship with that family. Forget it, because it will either be treated as a joke, they will do it in a way which will be destructive, or they'll come back, or they will leave treatment, the most likely thing. They'll just sort of disappear over the hill. I think the field of psychosocial treatment will begin more and more to move beyond family to social networks, as we've learned more and more about social networks and their importance in the preservation of health across the board. Whatever it is, if you have a social network, your recovery from things like acute myocardial infarction, from anything, is better, faster, and with less morbidity and mortality. The research on social networks is now really only 15 years old, which is relatively young. And I think that that's a place where we're going to begin to move, and it's the next logical place from families. That's the next step.
This concludes our program in the ongoing 1986 SK&F Psychiatry Audio Cassette Library Series, Update on Schizophrenia. Featured on this program were Drs. Thomas H. McGlashan and Loren Mosher. This program was recorded on location at the 7th Annual Vail Conference of the Menninger Foundation. SmithKline and French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual physicians. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline and French Laboratories or any other manufacturer of pharmaceuticals mentioned. This program was produced by SmithKline and French Laboratories and SK&F Co.